So Jeanette O'Brien, and I am the program and now accreditation coordinator here at Lutheran. We found through all these accreditations and things that we needed more of a point person who understood the programs, knows what we have to do to keep our accreditations up to date, and they're getting more and more complicated, it seems. So that is kind of a role I fell into, as well as our program coordination for all of our events and support and patient outreach. So just a boring little job over here.
What an understatement, right?
Yeah, as I said, yeah. So, and I'm just really excited to be here today and talk to you guys. I meet with Christy as often as we can, especially not much during COVID, and talk a lot about the reasons why we do a lot of what we do and hold events and how survivorship works. And Jen and I, Jen Cluse and I think have also talked about survivorship stuff. So it's an ongoing hot topic for everyone, I think, in the cancer community. So I think it's a really important and worthwhile thing to talk about. And I do know as we go through what the survivorship program looks like, I know people's resources can be very limited, and it can be difficult to try to do a survivorship program, but with so many moving pieces. So we're trying to show you the nuts and bolts and then simplify it a little bit for you as well. So I will get started. So I like to call it survivorship. Sometimes I call it my sinking ship, but definitely not a pleasure cruise for all of us. So that is our, come on. Now my share doesn't want us to change. Okay, so survivorship. Our why here at Lutheran is because we are accredited with our cancer program through American College of Surgeons, the COC, and the National Accreditation Program for Breast Centers, NAPBC. I know many sites are also looking at their the rectal accreditation program through the COC as well. We do not have that here, but it's very similar into what you would have to do for all the different pieces, and I would assume includes survivorship. Whether you're accredited or not all hospitals and cancer centers are accredited. The standards really work well for a model of care because they've collected lots of information from the entire cancer community to build these standards to make you a top-notch stellar cancer provider. So it's worthwhile to even dive into the standards even if you are not interested in being an accredited center. Survivorship. We all have heard so many different things and struggle a little bit, I think, with this. With ACS and all of our programs, we use the second bullet. If someone is a survivor, if they're living with, through, and beyond cancer. So it means it starts at diagnosis, including patients who receive it over a longer period of time. I think we lose sight sometimes of people who are in for a very long time. But many patients view it as having no signs of cancer after finishing treatment. So even things like Survivor's Day that we've been talking about can be difficult to explain to the patients that they are in their survivorship and that they are a survivor from diagnosis. So I think that is somewhat the first challenge. All the accreditations, why you have the accreditations. So I listed these here for you guys to look through later for people who aren't as familiar with it, but I'm guessing most everyone is, I'm not sure. So our current survivorship standards for the COC were released in 2020, and that was an update from, I believe, 2014, which was much needed because, as you guys know, as care changes, focus changes, they need the standards to change. So this is the current standard, very different from just the survivorship care plan model. So you can look at the standard, and things I like to highlight for people are measure of compliance and documentation are huge when you're reading these standards. It's like not only do we want it to fit what the standard would like us to do, the other piece of your accreditation is you have to have the right documentation and you have to be sure that you are measuring your compliance. If you don't do these two items, you can do a ton of great work for a survivorship program and not get the credit you deserve with the COC. NAPBC, new standards for them are coming out, we are hoping, soon. I've heard rumors of 2022. I think they're sending out standards for people to review and give input on now. If you are one of those people, I highly recommend that you give your feedback on the breast cancer survivorship care standards for NAPBC. I think many of us who have done survivorship care plans have found for really involved patients, they're very valued and worthwhile, but that's a small percentage of our patients. Many others, it's just another piece of paper, and it's not a medical record. And so there's that fine line of we can't give it to them and tell them it's their medical record. So its effectiveness is really being looked at. So your feedback is what the COC and NAPBC work off of. So the current standards summarized, because you can see they're long standards, it's 3 pages, is a delivery of a survivorship care plan to a minimum of 50% of all eligible patients that have received all or part of their treatment at your facility. This is an important piece because they could be diagnosed here and have a surgery, and we would still be expected to provide a care plan. That person has to play into our 50%. So it's very important to understand that part of the standard and deliver their SCP within the timing of the standard. So there's a lot to track. So, you know, they make these statements, it's just give it to 50% of eligible patients. Seems simple, but it's really not. Survivorship care plans. The current state, most of us that are doing these based on the ASCO guidelines. I know, Melissa, your practice was super involved in survivorship care plans, and we've partnered with you guys before as well. But again, they are studying the effectiveness and finding the impact of them is less than expected and less than they had hoped for the actual patients. We've done some surveys here out to our patients that receive care plans to get their feedback. Besides that, very few people responded. Some people said, I didn't even know I got a care plan. So that kind of speaks to what the meaning is to the patient. So the COC did actually hear us and look at that and modified their standard into a phase-in standard for 2020, which of course was complicated by COVID. But since they made it a phase-in standard, I think many of us were able to start working on it. We just had to be a little more creative. NAPBC, they're not going to change for now. Survivorship care plans are still the focus for your breast patients, and that's all patients 0 to 3, excluding metastatic. So the COC survivorship program, which is the new standard in 2020, is that your cancer committee oversees development and implementation of a survivorship program, meeting the needs of cancer patients treated with curative intent. You need to have a survivorship coordinator and team that develops a minimum of 3 programs. It can be an off-site referral program, but you would have to be able to capture that data from that program to know how many of your patients participated. So that's where the off-site can be a little tough, or a program you refer out to. And then all the programs need to address the needs of survivors, again, by that definition, which is also can be vague or up for interpretation. And then you evaluate and work on improvements to the program, and the expectation is there's some new programs annually. One of the caveats that's very important if you're looking at the COC standard is that if you are an NAPBC accredited facility, the survivorship care plans for breast patients are still required. So here we were all excited thinking we could do away with survivorship care plans as this requirement and include that for COC, but they said no, if you're NAPBC, it still has to be one of your 3 programs. So, and then they wanted you to include all cancers. So it doesn't really seem like much had changed, but they wanted us to add more programs. So we got a little more definition on that. So how do we develop a strong survivorship program? You need to first create your team and a committee. It has to be made up with some professional practice nurses or OCN certified nurses, and as well as physician engagement is good. We've got some MAs from our clinic, triage nurses from there, and representation from medical oncology as well as radiation oncology. You want to make your program small, attainable, and measurable. And I think survivorship, we all get very excited about. It's like, we can do these big programs for people, and then we realize you need a lot of people to do a big program. You need something that is you can set up and track, but you aren't going to have one full-time person just to keep track of it. I think we all know care plans themselves take quite a bit of time, especially for nursing and navigation staff. So you want to think about programs that are small, attainable, and measurable. You also want to be very diligent with your documentation, how you decided on the program. Use the SMART goals template. That's the nice way. It makes you answer all those questions that they would ask you. And they always also like to see that you show what evidence-based guidelines or research that you follow when you come up with your program. And meet regularly, document your progress, what's not working, and what you were going to do to update it to make it work a little better. Some things we plan just don't work. And so part of what people forget with the COC and NAPBC is it's okay to say your program failed, but you need to document the why it failed, what you tried to do to improve it, and if that didn't work as well. So I think the expectation on ourselves is that we create a program that will always be successful. And that's not necessarily the expectation. Their expectation is that you are continually trying to improve what you're doing. So program examples of the new survivorship standard programs, and again, this is the COC standard. In 2020, we chose to focus on our support groups, survivorship care plans, because we had to. So for our breast patients, and then all other cancers. And then the survivorship assessment and resource finder, and that was our newest standard that probably was, part of our dream. It's like, okay, let's create something that's all this resources in one. And so we were very excited. We wanted to do a class for survivors, but with COVID, of course, that wasn't ever going to take off in 2020. So we came up with this resource finder and some great things. So then what did we do next? Oops, my clicker's not working again. So our takeaways of our first program choices, support groups. We've been running them for years, easy to run, but we had to be sure we were tracking how many people were attending, and with virtual, that was a bit of a challenge. We tried to start presenting some topics quarterly or every other month to kind of entice discussion, and we made the topics a little bit more survivorship focused. When you're reporting to the COC on your standards, you want to use the word survivorship a lot, or be sure they understand that you are targeting survivorship with some of your topics. Support groups will have patients in treatment and beyond, so your topics have to fit both, but we were just careful again about how we documented. So survivorship care plans for breast and other cancers. We had started all cancers, and we thought we would just continue to give out all the care plans we had started. These patients who had already started treatment in 2020 as we phased in our standard. As we clarified further with the COC, which I'll show you guys at the end of the presentation how to find those clarifications, we realized we did not need to include all cancers. So that was one of our improvements we were going to make, is really deciding which, with our cancer committee, determine which cancers outside of breast they felt would benefit the most from having a survivorship care plan. And then we created the resource finder for the clinics, but discovered as that went on that it was much too large of a program. Again, we didn't keep it small. We made it attainable, but not, as we dug into how it was going to be able to be rolled out. So our current programs, because each year you have to present new or updates to your current program. We're continuing our support groups. We're continuing survivorship care plans for breast, because we have to. And then Cancer Committee determined we would give our care plans to head and neck and our GI cancers. We kind of decided that was due to their more complex nature, their treatment and surveillance. So we had the physicians talk that over with us, and Cancer Committee decided those were good cancers that may benefit from a survivorship care plan. We are doing what we call a survivorship assessment, and that is in both our RADONC and MEDONC clinics, and the survivorship resource binder. So our physicians and MAs and nurses have resources to give people for end of treatment. As we know, there's so many things that go on end of treatment, late and long-term effects, and all those things that we tried to cram into these survivorship care plans. We decided it'd be better to target what they need more and create a binder that gave the clinics the information they needed. Well, we discovered we were doing right. We met with our surveyor when we just had our survey recently for our new accreditation, is that we were adding new programs. We added the survivorship assessments program. We considered that a new program. Again, creative documentation. We meet regularly and we discuss each program at every meeting. It's easy to get bogged down with one of your programs. In your meeting, you want to be sure you look at every single one so you can report to your cancer committee that you're reviewing all your programs, not just one. We documented our identified successes and barriers, and we continually measured the number of survivors we were reaching through each program. So our program, survivorship assessment forms. We provide a form at each follow-up visit to any stage 0 to 3 patient treated in our medical oncology or radio oncology clinics. And the intent was that we wanted to kind of push that discussion between physician and patient about their survivorship, because we would have patients check back in with their navigators and have a lot of questions, or come to support group and have questions and realize, you know, they're kind of checking out the surveillance pieces and the tests they need and when they need to come back, but were they really addressing the concerns that a patient may be having, or is a patient forgetting to tell their doctor what side effects they're still experiencing? So we wanted to give them that avenue. We also wanted to allow them to set a goal for their survivorship for our very motivated patients who wanted to just get back out there and try and get back to normal. So this is our survivorship assessment form that we created. It's given to survivors starting at their 3-month follow-up after active treatment not including their AIs, of course. And then it's presented again at every follow-up visit, because we decided as a group, your survivorship needs may change. You may be on your AIs and weight becomes an issue. You may think, you know, neuropathy was getting better and now it's not. You may have decided you were going to quit smoking and backslid. So as patients change in their survivorship, we wanted them to be continually assessed. So they can decline to do the form. It's not a required form, but it is a way to get that discussion going. If the physician doesn't have time to review the form with them, their assessment, the MA or RN will go into the room and review it with them. If they set a goal, down in this area here, then the MA or RN sends a note to our survivorship oncology support team, which would be your social worker, dietitian, or navigators, to kind of help them be sure they have all the resources they need to attain their goals, especially if it's a health-related goal, mental health, eating, exercising. And then we send them out to all the programs, like Nancy's program, Epic Experience, is on our list, and we try to give them lots of different things to choose from to help them in survivorship. So this all triggers, it's not just a piece of paper. We try to make it trigger something, discussion between the doctor or resources. So our program 2 is the resource binder, and it's a nice complement to the assessment. So depending on what they fill out on this assessment, we can go to these categories in the binder and give them handouts and things. We are trying, and this is a lesson we've learned a lot over the years, to use resources that are out there in the community and already created. So there's, as we all know, there's a ton of different great programs, cancer.org, of course, ACS, and others you can go to, and you can get PDFs of these resources to hand to patients. So instead of creating all your own that someone has to maintain and that could go out of date, we try to use resources already existing in the community, and also target things that are in our community, like Epic and Live by Living for people who want to get active, so that they will use their local resources. And then we have our support groups. And again, it's not a new program for us, but we are continuing to keep it at least for 2021 as one of our chosen programs because we're trying to grow our support groups post-COVID. So we thought in the post-COVID era here, when people can start coming back in person, it made sense to continue this as a survivorship program. So to try and get people reconnected other than Zoom like we are here. And then we did add our metastatic group on here. And while you'll see metastatic is not included in the standards, we feel like after talking to and hearing from more metastatic patients, so many are surviving. They are surviving years and years with their disease. So while they're considered active treatment, we wanted to let them know that they had a space in this. And so we do talk to them about survivorship topics in some of their groups as well. And then, of course, our survivorship care plans are still a part of our program. I let you know how we decided on head and neck and GI. So for our 2021 diagnoses, we switched over to just those 3 disease sites, but we did agree we would try to finish all the ones that were in progress because those patients already had a care plan started and being reviewed. So pearls of wisdom on having an accredited survivorship program. Look for templates on these websites. They have lots of great templates you can use, so you don't have to start from scratch and say, how do I track this? What does it look like? We like what we call an activity report, and it has different tabs. The first tab is your committee members and meeting dates, and then metrics you're collecting, and just updates from your meeting, kind of like a meeting summary. I hate to call it minutes. It makes it so official. You want to keep things a little less official and do your official report out to your cancer committee. So you want to make good notes in that to create those reports. Whatever you decide on, you have to have had that approved by your cancer committee. So while we say these are our programs, we had to bring them to cancer committee, make sure they agreed with that, and we have it documented in our cancer committee minutes for the COC and in our BPLC, our breast program leadership committee for NAPBC, that they approved these survivorship standards or choices program. And again, keep it simple. You don't want to overwhelm your staff and your resources. So many of us are working where it's navigators and nurses and people who are very overwhelmed with your day-to-day activities. Same with what you're asking your clinics to do. We decided the survivorship assessment form was not going to burden them too much, and we're hoping eventually, if it's successful, we could move it into EPIC. So we'll always work for ways to make this easier and not a burden on the staff, but they are, as I call them often to our cancer committee, a necessary evil if we want to be accredited. So keeping it simple is helpful, and keep innovating. If they say you have to have 3 new programs every year, I don't think they're going to say that. The way I read the standard is that you have to approve your 3 programs every year, a minimum of 3. We can continue some from year to year as long as we're continually making improvements. So for instance, our support groups, at the end of 2021, if we've done all we can, we've gotten back on track after COVID, we're going to say, yeah, we're going to drop that off of our official survivorship program for accreditation. It will be a part of our program going forward because it was before, but we're going to replace it maybe with something else that we want to introduce. Again, being innovative and keep trying new things. So carry over what's still working and effective and replace those that are not, and then document your whys. That's what the COC wants. So here's the thing that I was really unaware of when I first started down the accreditation responsibility here at Lutheran, is that there's so many forums for NAPBC and COC both. And what happens is they're constantly clarifying and updating standards. So while you may have your book in front of you, we have a big binder with all the standards, or if you go online and you download their standards, there's also going to be clarifications. And that in itself probably should be on someone's radar at your site to do on a regular basis, like maybe quarterly, go in and look for clarifications. Because of feedback we all give them, sometimes they have changed things. We all remember for survivorship care plans, they changed the percentages required from 100% down to 50. COC went down to 25 before they dropped that standard. So you want to keep up on the changes to the standards. Otherwise, you may be doing work you don't need to do. So that's an important thing, and there's actual forms you can register for and have a meeting just like we are now. So on the COC website, you also can go for clarifications and put in your own questions or read other people's Q&A. And I do that a lot, and if I find some answers to things like that, you have to have 3 new programs every year for survivorship standard. I found that on the answer form that they didn't necessarily have to be brand new, but they had to be continuing, and we had to document that why we were continuing one program from one year to the next. So your clarifications on all these in your answer forms are, it's just somewhere you want to visit as frequently as you can, especially if you're introducing new things. You don't want to do work you don't have to do, and they'll all of a sudden just take away a requirement, and you may not have known that. So I really highly recommend using these sites. So here are links I included on here to some of the places where you can get information on all these survivorship items, and especially the FACS.org from American College of Surgeons. That's where you're going to find to get to all those programs. So, any questions?
Yes, that was very, very thorough and informative. Thank you. There are a couple questions that came in terms of, one of them is, how is the referral triggered for the assessment? I recall something about 3 months.
So the referral would be triggered if they want to set a goal, or the physician feels like when they visited with them about their questions that they want them to get a little more information, then they would put a referral. It's not necessarily going to be a requirement, and that's one of the things we're going to track with this standard or this program, is how many referrals are being triggered from the assessment.
Okay.
So if they set a goal, yeah.
In the Epic?
Yes, the referral would be sent through our in-basket in Epic. Okay. And it would go to either the social worker or the dietitian. Then they would funnel it on to the appropriate navigator. They'll kind of be our people to disseminate what the patient really needs. Okay. The rest of it is kind of up to the clinic to hand them the resources at that time.
Okay, very good. And then another question is, for the resource finder, is this in the MedOnc and RadOnc clinics? And have you been able to work with the PCP offices to link survivors to resources? Oh,
good question. We have a binder in each office. For our MedOnc, we have 2. We do a quarterly check of the binders, and we do track how many of each handout. So I set a par level, and when our person goes and reviews the binders, they'll let me know how many of each was being used. That also tells us what are the hot topics people need resources for. That's how we track that. So we just have a binder in each office. PCPs are just, I don't know if anyone else has any pearls of wisdom on PCPs. We send the survivorship care plans. If we do those are all sent to PCPs. It's really difficult to get in front of the PCPs to educate them more on survivorship. So that's been a tough one.
Okay, yes, I would agree.
I'll throw something in there. This is Melissa. And I really appreciate this presentation. I've actually found myself in the new role of being the survivorship program coordinator for our HCA Saracen and Denver INCP network. So we're living and breathing all of this right now, and I really appreciate it. A couple of years ago, I had a PCP in charge of a survivorship clinic say the one thing, because we send over our survivorship care plans, I, fax over a separate letter with bullet points to kind of highlight what the patient needs so things don't get lost in the fax shuffle. But she suggested making a phone call. She said, we would actually appreciate just a quick phone call from provider to provider on what the patients need, specifically what you need from us. And I thought that was interesting because you wouldn't think it'd be one more phone call or communication they have to deal with on a daily basis, but she preferred it and recommended it. And it wasn't just for her and her practice. It was kind of overseeing different survivorship clinics that she does.
Yeah,
so I don't know how that would work for you and your model with the different personnel that you're using to run your program. But if you have, clinic to clinic, if you have somebody that passes off that treatment summary, that would be an easy, quick phone call to make. It highlights the patient and they're more likely to remember that than just going through a whole bunch of medical records as they come in through the fax machine.
Well, and that's a great point, Melissa. I feel like part of this assessment and tool could be that instead of it just being sent to our own team, that maybe a goal that the patient has in survivorship is shared with the PCP. So again, it's not really the care plan, survivorship care plan, but it would be what they're seeing in their survivorship. Because we do also have that trouble, I'm sure other people do in their med-onc clinics, of handing off these patients. Sometimes they get so attached to their med-onc that they want them to still manage so much of that really needs to be managed by the PCP, things like health-related goals. So that's a really great point. Thank you.
Yes.
Yeah, and on that note, quick question. Do you guys have any PCPs on your COC commission or the larger committee?
We don't. We have all of our disciplines. Interestingly enough, the COC or NAPBC does not require PCPs as part of your cancer committee or BCL.
Yeah, I think that's very frustrating and unfortunate because, the crux of survivorship, the two providers really fall upon the oncologist and then the primary care, and avoiding that oncology black hole that patients fall into. There's so much more that needs to be quarterbacked by the primary care office, not just, current side effects of treatment, but long and short-term side effects that the oncologist may not necessarily manage as well as a primary care provider, bone health and other things like that. So I know I'm off on a tangent, but I think this is something very important to survivorship that we're missing. And I don't think these COC, the new standards, really address that as well as it needs to. And I think that's a very big area in which we can improve survivorship for many of our patients. Carolyn, you're on the call. What are your thoughts about that and engaging primary care physicians more routinely? Do you have any pearls on that for your program?
I don't think there is a Carolyn on the call.
Oh, Carlin.
Carlin, I'm sorry. Okay.
Carlin, how often do you get that, Carlin? Sorry. It's Carlin, right?
Yes. I think she
may be busy, but
yeah.
Okay. It's a discussion for another day. PCPs. We'll have to add that to the topic list. I don't mean to distract from your questions, though. These have been great answers.
I think that's a great idea. This is Nancy Farrow. So we're a nonprofit. So we hear from people constantly, probably after you guys are all really in the throes of it. And there's a huge disconnect, huge. Yeah.
I know, it's unfortunate.
We've been to PCP offices even, we go out in our community and sometimes we'll take our navigator and our manager and some people and get in front of the PCP and we've talked about survivorship care plans. But as far as something like the survivorship assessment piece, that would be an interesting thing to get in front of them and say, they could even do this with their patients that come in post-cancer treatment. But I think for all of us, and I think we've talked about this at some of the symposiums and things, and Christy, you're probably familiar too from groups, almost all the breakout groups we have, there was always that question of where are the PCPs, because they aren't always even at that big symposium that the coalition holds every year. So how do we engage them if we can't even get them into the discussion? But survivorship may be a way to engage them. Maybe it's a new buzzword,
Mm-hmm. Yeah, yes.
I just think as a discipline, they are so overburdened right now with EMR and the total care of their patients that, you know, one more form, one more program, one more thing they have to add to their plates, I think is burdensome just as is the general practice right now. That's why I thought the quick phone call about an individual patient was such a easy but brilliant idea. And then I'm just going to add another question since we're on this topic. Christy or any of you other task force ladies, do you remember one time Andrea Dreyer did some type of talk? I forgot, I think it started with an E, that you guys were offering some webinars, and we had a PCP on there who was very, very a strong proponent of survivorship care plans. He even submitted one himself that he would like to see. Do you guys remember who he is? And maybe we can reach out to him and find a champion, a PCP survivorship champion.
This was Becky. I was going to say Dr. Linda Overholser, but you're saying he, so I don't know if you're thinking of someone different.
Yeah, it wasn't her. And actually, Dr. Overholser is the one that recommended the phone call to PCPs. No, it was a gentleman. We'll have to circle back to it. I'm really glad this came up on the call today.
Yes, yes.
Yeah, I'll ask Andy and see if she remembers who that was, because I think that's an excellent idea, and maybe we could get them engaged on the steering committee to provide guidance to all the different task forces.
Yeah. Well, I'm sorry to wrap this conversation up because it sounds like it could go further, but in the interest of time, we have a couple other things we wanted to cover. I would say that now that you have Jeanette's contact information,